of cervical cancer. And in the bottom right is the global prevalence of adults living with HIV. And as you can see, these the distribution globally between HIV and HPV is very, very similar. As we know, cervical cancer is one of the deadliest cancers in women worldwide, resulting in over 300,000 deaths per year globally. This talk is specifically HPV infection in women living with HIV. Women living with HIV are especially vulnerable to cervical cancer. They experience rates 6 times higher than women without HIV and experience higher rates of prevalent and persistent infection that progresses more quickly to precancerous lesions and invasive cervical cancer. And this is due to a multitude of reasons, specifically the HIV virus compromising the immune system, which increases the likelihood of infection that persists and progresses more quickly. The prevalence of HPV in women living with HIV is approximately twice that of non-HIV individuals. And when I'm with regards to prevalence, I'm talking about the total cases of infection within a population. Whereas in comparison, the incidence of HPV varies within the literature from 3 to 10%. And when I'm talking about incidence, I'm talking about the number of new cases of HPV infection within a population at a certain time point. And the range of 3 to 10% really emphasizes the importance for population-specific analysis when looking at rates of positivity. So BC is one of the first provinces in Canada to launch primary HPV screening and self-sampling as a standard practice of care. However, rates of HPV positivity and need for colposcopy, as well as optimal screening intervals for women living with HIV, is not clearly understood. So the objectives of this project were to determine the rates of positivity, specifically prevalence and incidence of oncogenic HPV in women living with HIV in Canada, as well as to compare the rates of oncogenic HPV positivity in women living with HIV with an HIV negative cohort. And these steps are kind of to eventually help determine the optimal screening intervals for women living with HIV as we implement HPV testing within our province. So the data that was analyzed was from the HPV and HIV study group from a prospective longitudinal immunogenicity cohort study of unvaccinated women living with HIV from 14 sites of HIV care across Canada from 2008 to 2015. Specifically in this analysis, we looked at 2 time points, the screening point and the baseline point, which is a 3-month time period between the two, where we calculated rates of positivity, specifically incidence and prevalence of 14 types of oncogenic HPV at the screening and baseline interval. So out of the 289 participants within the study, the median participant age was 39, and 70% of participants had a suppressed viral load of less than 50 copies per milliliter, as well as 510, median CD4 T cell count of 510. Overall, 46.4% of participants tested positive for at least one type of oncogenic HPV. And in comparison, in a Canadian study, of a general population, the prevalence of oncogenic HPV infection was approximately 8.1%, so significantly higher. Of the 4 different types of HPV, the highest prevalence was in HPV 16 at 9.7%, HPV 52 at 10%, and HPV 58 at 7.3%. Specifically looking at the incidence of HPV, so this was the rates of new HPV infections within a 3-month time period from screening to baseline. The highest incidence of HPV was in 3.8%, 2.4%, 2.1%, and 2.1% for types 52, 16, 31, and 56, respectively. So to kind of summarize all of these findings, within a Canadian population, there were very high rates of oncogenic HPV positivity. And looking at the current recommended screening algorithm for women living with HIV in Canada, of the 289 participants, 134 tested positive for at least one type of oncogenic HPV, and therefore, looking at the current screening algorithm for women living with HIV, 134 participants, or 46% of participants, would be referred for colposcopy. So to kind of conclude my presentation, the point that I'm trying to get across is that the current screening algorithm for women living with HIV will result in many referrals for colposcopy, with the potential for repeat colposcopies as the persistence, women living with HIV experience higher persistence of HPV infection, around 33%. I would like to thank my supervisor, Dr. Deborah Money, as well as the HPV and HIV study team, the CTN, CIHR, and the WHRI, as well as Dr. Elizabeth McClymont, Emma Carlson, and the rest of the RID team. Thank you so much, and I'll be happy to take any questions.
Thank you. Good morning, everyone. Thank you so much for having me here today. So my name is Alex Lukey, and today I'll be talking to you about exploring acceptability of risk-reducing salpingectomy, the patient perspective. So this group won't need too much background in this, but we know that ovarian cancer continues to be a leading cause of death worldwide. And one of the main drivers of this is really a lack of options for screening. In 2021, the largest clinical trial to date published that there was no mortality benefit for screening for ovarian cancer. So we really need to focus on primary prevention interventions. We also know that there are 5 distinct histotypes for ovarian cancer, with 90% of the deaths being driven by just one, just high-grade serous ovarian cancer. And this is also relevant because in 2006, there began to be accumulating evidence that most high-grade serous cancers actually start in the fallopian tube rather than the ovarian surface epithelium. And this led to a prevention opportunity called opportunistic salpingectomy. So this is taking the opportunity to take the fallopian tubes out for people who don't wish to have any future pregnancies at the time of another surgery. So this is usually hysterectomy or instead of tubal ligation. And this was started right here in BC, and the outcomes for the first cohort of patients that received opportunistic salpingectomy were published in 2022, and it was found that there were actually 0 cases of high-grade serous cancer in the group that received opportunistic salpingectomy, which was significantly fewer than the control groups of hysterectomy alone or tubal ligation. So with all this in mind, about 10 years of safety and now efficacy data, we're starting to ask the question, is it time for a more targeted approach for salpingectomy? So also note, so people at very high lifetime risk of ovarian cancer, so this is the people such as the BRCA variant carriers, are offered what's called risk-reducing salpingo-oophorectomy. Some work has been done that this might be worthwhile at above a 5% lifetime risk of ovarian cancer, but still a little bit of an open question. And what we're talking about isn't the people who would be at average or below lifetime risk, but there's really this middle risk group that really isn't currently being offered any kind of primary prevention interventions. We also know a fair amount about what puts someone at risk for ovarian cancer or what protects them from ovarian cancer. And this has also been used to create risk prediction calculators, such as CANRIS, that also use a polygenic risk score. So we actually can do a relatively good job of estimating someone's ovarian cancer lifetime risk. So with this in mind, we started to wonder, what does the public think about this? So we aim to, with this research, talk to people in the general public through a survey, just to start to begin to understand the acceptability of if we were to move towards a risk-reducing model. So salpingectomy is a standalone surgery for ovarian cancer prevention. So you wanted to know, is there a lifetime risk that people, from the patient perspective, would warrant this? We wanted to understand their perceived acceptability. So you can measure satisfaction only retrospectively after someone has had an intervention, but you can actually measure acceptability prospectively, so before someone's been offered or given an intervention. We want to understand if there's individual characteristics that might make it more likely that someone might find this acceptable. And then finally, understanding what are the main concerns from the patient perspective if this were to be offered. So what I'm presenting today is the first part of a mixed method explanatory study. So this is the results from a province-wide online survey. We aimed for around 210 responses. We wanted people that were adults with no intention of future pregnancies, not having the genetic variants that would make them eligible for oophorectomy, no history of gynecologic cancer, and then not having already had a salpingectomy. So we used REDCap to collect data and used descriptive statistics and multivariate regression to answer our research questions. So about 217 people answered this survey. 6% had missing outcome data, so we excluded those folks. On average, age was 44 years old. Just under 5% identified as transgender or non-binary. Just under 18% lived rurally. And then quite a highly educated sample, so just over 70% had either an undergraduate or postgraduate education. So what did we find? So of the 211 participants, 43% said that they would actually consider risk-reducing salpingectomy either at any lifetime risk or anything above the population average of 1.4%. Just under 6% say they wouldn't consider this no matter what their lifetime risk was. And then the remaining 51.3%, so the majority, said it would depend. So somewhere between 1.5 to greater than 10% as would they felt would warrant risk-reducing salpingectomy. And then when we looked at patient-level factors, we really didn't find anything that was significantly predictive of whether or not someone would find this more or less acceptable. Regarding concerns, so by far the largest concern was the concern related to risk of surgical complications. And then right after that was people not wanting to have a preventative surgery. So not wanting to have the surgery unless it was absolutely necessary to maintain their current health. Regarding, so we had one open question, so if they had other responses, and the majority of people that filled that out, their concerns were related to undergoing general anesthesia. So some limitations, so this is a non-randomized sample in the province, so that opens us up to some sampling bias, so both observed and unobserved ways, so these folks might be more interested in their health, higher health literacy than people of the general population. With some strengths is doing an online survey. We did have pretty good geographic reach and a fair amount of variability within our sample. And then the next step of this project is going to be doing interviews with a subsample of those patients. So we're going to gain a more in-depth understanding of how people are thinking about this. So regarding future research and implications, so really when we're talking about moving from this opportunistic salpingectomy model to a more risk-reducing targeted model, it's really important to understand what patients think about this and what they think is acceptable and if we should move forward with this, because of course this is always going to be a completely elective decision. So next we're going to be also talking to OBGYN, so talking, getting the clinician perspective, and then as I said, doing a subsample of these people. We're actually going to give them their estimated lifetime risk score using CanRisk, and then talk to them again to gain a more in-depth understanding of how patients might be thinking about this if we were to head this direction. But really the overall goal of this work is to understand how we could use this primary prevention intervention to prevent as many cases of ovarian cancer as we can globally. So with that, I'll thank my supervisory committee, so Dr. Jillian Hanley, Dr. Michael Law, all our team members, many of which are here today, and then the funding that supported this work. And happy to take any questions, and my email's there as well if you wanted to chat after the conference or just come find me. Thank you very much.
Yeah, thanks. All right, thanks everyone for having me here. So my name is Ramlogan. I work with Dr. David Huntsman and Dr. Jillian Hanley on opportunistic salpingectomy. So the general population lifetime risk of ovarian cancer is about 1.4%. About 80% of ovarian cancers are found within the general population. Now I bring this statistic up primarily because my project is focused on individuals from the general population and not high-risk mutation carriers, such as those of the BRCA1, BRCA2 category. So within this BRCA1, BRCA2 category, however, there are about 20 to 25% of ovarian cancers that occur in this population. Also note that high-grade serous ovarian carcinomas are the most lethal ovarian cancers. So with that in mind, what I wanted to do is discuss a bit about precursor lesions in high-grade serous carcinomas and where they come from. So this is just a schematic detailing the stepwise progression of ovarian high-grade serous carcinomas from the normal fallopian tube. So it undergoes a series of changes, including loss of p53, loss of polarity, loss of ciliated cells, moving from normal fallopian tubes, then progressing to a p53 signature, which is a strip of 10 to 12 consecutive cells that have p53 mutations, which then progresses into a stick. So that's the serous tubal intraepithelial carcinoma, and then eventually the high-grade serous carcinomas. So current methods of surgical intervention are primarily based on BRCA mutation carriers, so that high-risk population group. And currently what's proposed is the removal of both the fallopian tubes and the ovaries. However, this procedure can't be applied effectively to the general population, primarily because it puts a woman into early menopause, and that's associated with other health implications such as cardiovascular and skeletal issues. So in 2010, researchers here led by Dr. Diane Miller proposed opportunistic salpingectomy. So this is the for the general population. So this is the removal of the fallopian tubes while leaving the ovaries intact for the prevention of ovarian cancer. And this procedure was also proposed to be done alongside other surgeries such as a hysterectomy or in lieu of tubal ligation. The overall premise was based on the fact that the high grades derive from the fallopian tube. So if you remove that, then effectively you're removing the source of origin for these tumors. And also, we suspected that it would have an impact on clear cell and endometrial carcinomas, primarily because these two cancers use the fallopian tube as a conduit for the dissemination of endometrial cells. So when we look at the overall progression of when a stick develops at one time point in a woman's life following ovulation, it's usually around this 20 to 25 year period. And we propose the removal of the fallopian tubes primarily after an individual has had their children. And the idea is that if you can remove, again, that source of origin at an early enough time point, then you can effectively reduce these cancers. So my project is primarily focused on two main points. So the first is I want to figure out what the histotype distribution shift following the procedure is. And the second is to assess any tumors that arise following an opportunistic salpingectomy and determine how different they are compared to those individuals, those cancers that come from individuals with their fallopian tubes intact. There's a group of individuals out there that say that some of these cancers, the high-grade serous carcinomas, come from the ovaries. And so if that is true, then within my cohort, that population would be enriched. So briefly, this is just a schematic of what I will be doing. I'll be assessing pathology reports to identify the histotype distribution shift, and then performing shallow whole genome sequencing to assess those cases qualitatively. Now, to tackle these questions, in 2022, we initiated the Ovarian Cancer Observatory, led by Dr. David Huntsman and Dr. Jillian Hanley, along with various other researchers, many of whom are here. And the goal in mind was to first assemble an international cohort of participants. So we primarily used the REDCap to capture cases. Our goals are to capture 150 cases and 300 controls. So far, we've interacted with a variety of collaborators from across the world, primarily here in Canada, the US, and across seas within Europe. So this is just a list of some our collaborators. But going into this project, we did have an expectation, so we wanted to figure out by how much this reduction, we could see this reduction. So based on that previous BRC cohort, we expected that this procedure would reduce high-grade serous carcinomas by 80% and would also reduce clear cells and endometrioid carcinomas by around 40%. Now, when we actually look at the data, it's actually a lot more surprising. And what you'll see is that there's a significant reduction, or there is a reduction in those high-grade serous carcinomas. So you'll see this blue, the N equals 3. So now within the overall pie, we see that it's high-grade serous carcinomas no longer form the majority, but are actually in fewer numbers compared to the other histotypes. And when we look at all ovarian cancers, what we can see is that there's a distribution of these cancers, but what you'll notice is that those high-grade serous carcinomas, again, in that blue, are fewer in proportion compared to other histotypes. Now, we did look at one high grade that had a stick, but so this patient had a stick lesion, and they still developed the carcinoma, but this is not necessarily because of a failure of the procedure. It was just that the procedure was carried out after the stick had disseminated to other parts of the peritoneal cavity. So in conclusion, opportunistic salpingectomy is effective at reducing high grades, but further work is still required to characterize post-opportunistic salpingectomy cases. And I'd just like to thank my supervisors, our collaborators, and this is just a list of all our collaborators. Yeah, thank you so much.
Thank you. And now for something completely different from the rest of your day. I'll just forewarn you. I'm presenting from a global health perspective about cervix cancer in Tanzania. Cervix cancer is considered to be the largest cancer equity issue facing women worldwide. I'm a new researcher, but I'm also a family physician and palliative care physician for the last 30 years, working on Saanich Peninsula and Vancouver Island, and also working in Tanzania supporting palliative care services and cervical cancer screening services for the last 15 years. I'm privileged to have Dr. Gina Ogilvie as my supervisor in the Clinician Scholar Program. By the end, you'll have been exposed to cervix cancer as a global issue, as well as the WHO elimination strategy that Dr. Money mentioned, and also the extra challenges of measuring screening and treatment outcomes in Tanga, Tanzania. So why this dual focus of palliative care and cervical cancer screening? Bombo, the hospital where we work, is the largest regional referral hospital in the Tanga region, the only one actually, and we reviewed our palliative care registry data and found that 60% of the female cancer deaths and 30% of female deaths overall were due to this single diagnosis of cervix cancer. The prevalence of HIV in sub-Saharan Africa was 8 to 9% when we arrived in 2008, and we've seen a steady shift away from HIV towards an epidemic of deaths from cervix cancer. 1 woman dies every 2 minutes worldwide. However, 9 in 10 occur in low and middle income countries worldwide. Women living with HIV are 6 times more likely to develop cancer of the cervix than women who are HIV negative. So it is a preventable disease via vaccination, screening, and early detection. The WHO introduced the strategy for elimination in 2021 with its easy-to-remember 90-70-90 slogan. 90% of girls vaccinated by age 15, 70% of women screened, and 90% of women identified with cervix disease receiving appropriate treatment. So how is Tanzania doing? With its incredibly high incidence of 62.5 per 100,000, I think it's one of the very highest in the world. 4 in 10 girls are vaccinated by age 15, and only 1 in 10 women has received screening in the last 5 years. And there is absolutely no data reported about that all-important third bubble, the treatment coverage, which is the proportion of women identified with a cervical lesion who receive appropriate treatment. In this WHO...
Jim Patterson Pavilion, ground floor, station 4 CT scan. Code blue, Jim Patterson Pavilion, ground floor, station 4 CT scan. Code blue, Jim Patterson Pavilion, ground floor, station 4 CT scan.
In this WHO list of strategic actions to improve treatment coverage, I draw your attention to the second bubble to establish care pathways and referral networks for cancer of the cervix and its precursors, and this is where my research is focusing. So back in 2011, the National Cervical Cancer Screening Program was introduced, called CECAP, but not in the Tanga region where we work until 2016. CECAP is a VIA-based screen and treat program, which was the state of the world in 2011. VIA standing for visual inspection with acetic acid. The challenges of managing the treatment cascade that should follow a VIA positive result was immediately apparent. So aceto-white lesions are graded into 3 categories for VIA positive women: small to moderate lesions, large lesions, suspect cancer. So the accuracy, obviously, and quality monitoring is extremely challenging, with generally poor sensitivities and high levels of false negative results. For this reason, the new WHO strategy recommends moving from screen and treat to screen, triage, and treat using a high-performance HPV swab. However, regardless of what screening tool is used, there is still an urgent need to link those positive screens to the appropriate treatment cascade. Here's a couple of our nurses who are doing sort of 15 to 25 screens in an afternoon. There are now 48 other cervical cancer screening clinics across the Tanga region. This is the standard paper CECAP ledger, where all encounters are recorded across the country. We digitalized the first 3 years of screening at Bombo, capturing demographics such as age, parity, HIV status, VIA outcomes, and the treatment provided. So this is a very large data set, but today I'm just focusing on treatment coverage. So Bombo is also the only hospital in the region where women can obtain LEAP and biopsy and a referral for cancer care.
I'm going to have to go because my meeting has started.
The cancer care, which is 7 hours away by bus in Dar es Salaam. This second ledger was developed to document the treatment cascade for women who needed a biopsy. So tracking a woman's CECAP journey from VIA positive screen through to treatment means documenting and measuring the prescribed treatment pathways for each outcome. So same-day cryotherapy for small lesions, LEAP for large lesions, and biopsy for suspect cancer. Ensuring women receive their biopsy results is also important, and the appropriate referrals for cancer care, for earlier stage disease, and palliative care for advanced disease. So analysis of our data set shows 2,289 screening encounters. 70% are women living with HIV. 10% overall showed a VIA positive rate. And really the most remarkable thing is that more women had suspect cancer on visual exam than had small treatable dysplastic lesions. So defining treatment coverage really means identifying the measurable elements of engagement in treatment coverage. So how are we doing in those first 3 years? Only 57% of women received same-day cryotherapy for small lesions. So that means that 43% are lost to follow-up at this very important preventable treatment juncture. 48% who had a large lesion received LEAP. Biopsy was completed for only 64% of women with suspect cancer. And of those, 18% had no documented biopsy result. So astonishingly, of those 310 biopsies who had a result back done for suspect cancer, visually, 90% had a confirmed diagnosis of CA cervix. So in summary, a very high percent of confirmed cervical cancer diagnoses from VIA screening when suspect cancer is is visually recognized. There are large gaps in screening and treatment, in the treatment cascade. And I finish with this slide because it is really going to be person-centered linkages that will strengthen the pathways between screening and treatment. My current research project is asking, can the introduction of a treatment navigator help to improve treatment coverage and reduce the number of loss to follow-up for women in the Tanga region? That's it.
Hi, everyone. Thank you to the GCI for allowing me to present today. I'll be talking about the publication entitled Opportunistic Salpingectomy, a Descriptive Analysis. So I'd first like to acknowledge that I'm on the traditional and unceded territory of the Secwepemc people in the southern interior of BC. So as mentioned in previous talks today, opportunistic salpingectomy is the removal of fallopian tubes during another procedure such as a hysterectomy or instead of a tubal ligation. In 2015, the Society of Obstetricians and Gynecologists of Canada recommended that this procedure to be done in the general population to prevent ovarian cancer, and in the years following, many other countries followed suit. Research has shown that it is a safe and feasible procedure, and even more recent evidence shows it is effective in reducing risk for ovarian cancer. With OS being a primary prevention strategy, it is important to know how often this procedure occurs, especially on a national level. So the first national study on hysterectomies with bilateral salpingectomy was published in 2013. And they show here that uptake was less than 15% in all provinces, except for BC, from 2006 to 2011. Our research lab published a study a couple years ago showing national uptake data from 2011 to 2016. This study showed that hysterectomies with OS increased from 15% to nearly 36%, and tubal sterilization with OS increased from 6.5% to 22% by 2016. BC still had the highest rates of OS. However, the study also showed that there was considerable variation across jurisdictions. Therefore, we wanted to follow up with more recent data. So the objective of the study is to describe the rates of OS at the time of hysterectomy and tubal sterilization and examine how they changed between 2017 and 2020. This was a retrospective descriptive analysis, and the databases used were the Canadian Institute of Health Information's Discharge Abstract Database and the National Ambulatory Care Reporting System. So we included anyone who had a hysterectomy as well as those who underwent tubal sterilization and grouped them by the type of the procedure that was done. We excluded anyone under 15 years of age and anyone diagnosed with a gynecological cancer. So simple proportions were calculated. Each procedure were analyzed across each year. OS rates were compared over time and across included Canadian jurisdictions. The rates of OS are presented by patient age group at time of surgery, neighborhood income quintile, and rural or urban residents. So the final cohort included approximately 174,000 people. For uptake of OS in Figure A, we can see that hysterectomies with OS increased from 31% to nearly 40% in 2020. The rate of hysterectomy with BSO remained stable at 27% in green, and the rate of hysterectomies alone in blue decreased from 41% to 32%. Figure B shows that the proportion of people getting OS for sterilization increased from approximately 26% to 42%, which represents a 62% relative increase over time. In terms of variation and uptake of OS across Canada, you can see by the color of the maps from 2017 to 2020, it gets darker in shade, representing a larger increase in rates of hysterectomy in Figure A, and tubal sterilization, including OS in Figure B. Every jurisdiction had increased rates of OS. In Figure A, we see that hysterectomy with OS in green were highest among those in the 25 to 34 and the 35 to 44 year age groups. And for OS for sterilization, the most common age group was in the 45 to 54 age range. So for OS by geographic region of residence, there was minimal variation. However, hysterectomy with OS and OS for sterilization, it was less common in rural, remote areas. So this study shows that there is considerable improvement in uptake of OS across Canada, increasing to nearly 40% of all hysterectomies in 2020. Given that hysterectomies with BSO, although not technically opportunistic salpingectomies, they also remove the fallopian tubes, 68.1% included fallopian tube removal in 2020. Also, while 26.3% of tubal sterilizations were OS in 2017, This has increased to 42.5% in 2020. This is considerably more uptake than what we previously published and supports what gynecologic surgeons have been telling us, that uptake is now much higher than before. However, there are still many missed opportunities for ovarian cancer prevention, specifically 49,200 tubal ligations and 36,900 hysterectomies were done, leaving the fallopian tubes behind. So some limitations in the study are the reliance on administrative data, as well as the inability to study uptake by surgical approach. Given the importance of equity and access to OS, future research should specifically examine barriers to uptake in rural Canada. So in conclusion, the uptake of OS increased significantly between 2017 and 2020, and most Canadian jurisdictions included. However, there are still many missed opportunities. But now that preliminary evidence on the effectiveness of OS in preventing serious cancers has been published, efforts should be increased to ensure that all eligible people are offered OS. And that concludes my presentation. I'm open for any questions. Thank you.
Hey everyone, so today I'm going to be presenting some preliminary results from my master's thesis. I'm going to hop right into the background and rationale. Sorry, we're having some technical difficulties, but I think it should be okay. So as many of us know, there is no effective screening for ovarian cancer. And for this reason, it's very important to identify risk and protective factors for the disease. So I've highlighted a couple risk and protective factors here. These aren't all of them, but these are kind of the main ones that are important here. So for risk factors, we have genetics, so things like BRCA mutations, as well as a family history of ovarian cancer. Also age, so as age increases, so does ovarian cancer risk. For protective factors, we have parity, so more births throughout the lifetime is protective against ovarian cancer, as well as fewer lifetime ovulations. And really important here is hormonal contraceptives, or HCs. These have been consistently shown to be very protective against ovarian cancer. However, as people move more towards other contraceptive forms, such as the IUD, it's important to understand how these different forms of contraception may affect ovarian cancer risk. So what is the LNG IUD? This is a progestin-only form of long-term contraception. It releases levonorgestrel, which is shortened to LNG, and this prevents pregnancy by thinning the endometrial lining. This is implanted into the uterus, and the most popular form is the Mirena. So there's been 3 studies looking at the LNG IUD and ovarian cancer. These 2 studies from 2016 and 2018 found that the IUD did reduce ovarian cancer risk. However, another study from 2018 found that there was no decreased risk of ovarian cancer with IUD use. And really importantly, this study controlled for prior hormonal contraceptive use, whereas the 2 previous studies had not. So given these conflicting results, we wanted to add more research to the literature, which also controlled for prior hormonal contraceptive use. So for our analysis, we linked together multiple data sets, including, and these were population-based data sets from BC. The first one was Vital Statistics, which has information on all births and deaths in BC. The other one was BC PharmaNet, and this has information on all medications dispensed in BC. So we use this to get information on IUDs as well as hormonal contraceptives. We used the BC Cancer Registry to look at our outcome, ovarian cancer cases, and health services data to look at insertions and removals of IUDs, as well as demographic information. So the exposure variable was having both an LNG IUD prescription and an insertion fee in the health services data. Our cohort was made up of all female individuals from BC of reproductive age, so those were people 15 to 50 in 2002. We excluded anyone with a previous cancer with infertility treatment, as this may increase the risk of ovarian cancer. We also excluded people with venous thrombosis, as this can affect contraceptive choices, as well as anyone with oophorectomy or salpingo oophorectomy. The statistical analysis was a Cox model with LNG IUD use as a time-varying covariate. So essentially, people were considered unexposed until they had the IUD inserted, and then they were adding time to the exposure once they had the IUD inserted. We controlled for prior HC use and age. HC use was also a time-varying covariate, and individuals were censored at end of follow-up, at pregnancy, at a move out of the province, or any of the exclusion criteria that I mentioned above. Okay, so getting into the results, our final cohort had almost 819,000 individuals after we applied the exclusion criteria. Around 56,000 of these people were exposed to the IUD. We definitely saw some big differences between the groups. So you can see here in the chart, the people who were exposed to the IUD were on average quite a bit younger, around 27 years in 2002, compared to around 35 years old in the unexposed group. We also saw differences in parity, so there were a lot more people with 0 live births recorded in the unexposed group compared to the exposed group. And we also saw differences, as we expected, in HC exposure, where there was a lot more exposure in the IUD group compared to the unexposed group. Oh, also really important here is we had very few ovarian cancer cases in the IUD group. We only had about 15, or we had 15 compared to 1,208 in the unexposed group. So these are the results from the main analysis. We found a crude hazard ratio of 0.25 and an adjusted hazard ratio of 0.43. The adjusted model adjusted for age in 2002, hormonal contraceptive use prior to 2002, as well as post-2002. So here we did see a protective effect of the IUD, and this is in line with those 2 previous studies which I showed earlier. There are definitely some limitations with this work. We did have a really small number of cases in the exposed group. As I mentioned before, it was only 15. And due to this really small number of cases, we weren't able to control for parity, although we were able to control for HC use and age. There were also those differences between the groups that I mentioned before. And while we were able to control for the hormonal contraceptive use and age, we weren't able to control for parity, and there may be some residual confounding. We also had lack of information on some potential confounders like family history, and this is inherent in population-based research. In conclusion, the IUD does appear to protect against ovarian cancer, at least according to these preliminary results. This is in line with 2 previous studies, which had hazard ratios around, or quite similar to our hazard ratio. The small number of cases did limit the analysis, and for that reason, further research is definitely needed, hopefully with a larger number of cases. These are my references, and I just want to say thank you so much to Paramdeep and Elena for all the work they did on this analysis, and for helping me with all my questions, as well as Dr. Jillian Hanley, my supervisor, and the whole lab. And also thank you to these funding agencies. I'm happy to take any questions.